Thank you to invite me to speak about in situ laser fenestration in ruptured abdominal aortic aneurysm following a type 1A endoleak. 86-year-old male patient was referred to our institution for a residual type 1A endoleak following a traditional infrarenal EVAR performed 8 years ago using a Medtronic endurance stent graft and subsequent multiple failed embolization attempts during the last 3 years. A CT scan showed an aneurysmal sac of 83 mm diameter with evident type 1A endoleak and no LC infrarenal neck. Also, the proximal bare stent of the stent graft partially covered the left velar artery's ostium. The patient was referred to preoperative anesthesia-related assessments and was deemed unfit for open surgery. The chimney graft technique, CHIVA, was possible but required at least 3 chimney grafts to obtain a minimal 15 mm proximal sealing in non-aneurysmal area, increasing the risk for residual type 1A endoleak. Standard fenestrated EVA or FEVA was ruled out because of a long manufacture delay. Identically, aortic stent graft with in situ laser fenestration for veno-visceral ostia, also called LIVA, had been practiced in non-emergent, non-rupture configuration and was chosen in the present case. We have in press an article that will be published soon in the European Journal of Vascular Surgery presenting our series of laser fenestration compared to company manufacturer stent graft in complex AAA repair. And we have shown that the 12 months survival rates were 91% and target vessel patency rates were 95%, so quite acceptable result. Most of the time we used taken endurance stent graft that is placed within the aorta in front of the veno-visceral ostia. Fenestration are done using Aptis LAFX steerable catheter and Turbo Elite laser atherectomy catheter. In the meantime, the patient was admitted for hemodynamically unstable acute abdominal pain. An urgent CT scan was performed showing a 99 mm diameter rupture abdominal aneurysm with a large retroperitoneal hematoma. The patient was immediately transferred to a hybrid operating room. First, a resuscitative endovascular balloon occlusion of the aorta reboa through the right common femoral artery was put, and then the procedure took place under a general anesthesia. First step consisted to perform images fusion using CTA overlay or image fusion facilitate laser fenestration by displaying reliably the origin of target vessel. And target vessel artery ostia landmarks were represented as rings. In the second stage, using CTA overlay, the endoprosthesis endurance proximal extension was placed within the renovisceral aorta above the previous endovascular graft. In the third stage, the Aptis LAFX steerable catheter was inserted through the femoral artery and curved face to the osteum marker at an angle of 90 degrees. At the first stage, the fenestration was made using a turbo elite laser catheter. We can see here the advancement of the laser atherectomy catheter, followed by the perforation of the graft. Here we can see the perforation. It's very brief. Then the perforation is enlarged by using a predilatation with a 2.5 millimeter cutting balloon, followed by a 4 millimeter balloon dilatation. Then 7 French sheath is inserted, permitting to deploy a covered stent, for example, a V12 ICAS stent or a Bentley stent, as we normally do in fever case. Finally, an undergraft proximal extension with 4 fenestration for visceral arteries was performed. Follow-up was uneventful, and final CT scan show a perfect deployment of stents through the fenestrations and the complete exclusion of the AAA. In conclusion, the advantages of lever are their possible use in emergency or for bailout cases. Lever does have less anatomic restrictions than fever. Lever use lower profile undergrafts. Lever could favor faster and simpler procedure than fever. Lever could be cheaper than fever, half price. One question remains: the durability of lever. Thank you very much for your attention.